BirthFit Podcast, episode number 271. I am Dr. Lindsey Matthews Cantu. I am your BirthFit founder and CEO. Today, we've got a juicy episode all about preeclampsia. And y'all, I've been wanting to record this for quite some time, but I needed to get my notes in order because this episode needs to be shared far and wide because preeclampsia does not mean induction. And that's what I feel like our world equates it to. It's automatically an induction. Anyways, before we get into the juice, the BirthFit certification enrollment is open right now. We've got an early bird special going on. When you sign up right now, you will get a nice discount and you can start watching all the modules already. Our live calls are this fall, so you would be signing up for the fall cohort. And all calls are once a week, September, October, and the first 2 weeks of November. If you wait, the price goes up. That's all I'm going to say. And I can't change the price because I'm telling you now, and I will keep my word. Um, if you are a coach, if you're a personal trainer, if you're a chiropractor, a physical therapist, a midwife, an OB, a nutritional therapist, an acupuncturist, we've had all of those inside of the BirthFit certification. I promise you, on the other side, the women of your community will walk into the motherhood transition more aligned, more grounded, and confident. You will be able to hold the door open for them with confidence and clarity using your expertise. You will be able to apply the framework. If you're a chiropractor, I guarantee this is more than a weekend technique seminar. If you're a coach or a personal trainer that's taken a previous prenatal or postpartum certification, I guarantee this is more. Oh my God. Um, we are the only lifestyle medicine perinatal certification out there. So make it happen. And this episode literally is a beautiful insight into the BirthFit framework, the BirthFit perspective, and how we think. This 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 subject is so deep, y'all, but we're gonna ideally get through it super quick. And if you want more in-depth conversation around this subject matter, get into the BirthFit community. That is the place to be. We have weekly discussions, we have guest speakers, we have office hours, we have mindset and movement, one call a week, Tuesdays, let's go. But this perspective on this particular subject, like within BirthFit, we have this framework, we have this lens, and with all things, this can be applied. And so this is a beautiful example of that. Preeclampsia, it is more than a diagnosis. And if you are a coach or a practitioner, you need to know this stuff. If you're a mom and you've been diagnosed with preeclampsia in a previous pregnancy, this is an episode for you. If you are thinking about getting pregnant, this is an episode for you. As I will get into, preeclampsia starts long before pregnancy. So, y'all, every time a woman hears the word preeclampsia, usually the next word is induction. And hopefully by the end of this podcast, we're, you will have a beautiful perspective, some options, some communication skills as we're going to sit in that space between those two words. Um, so what we're going to get into is the data. We're going to talk about the global burden, the rising rates. We're going to talk about the diagnosis. We're going to talk about conventional care, because that's always good to know, right? Even if you don't choose that. Like I don't choose conventional care. What I vibe more with is the traditional wisdom. We're going to get into traditional wisdom. We're going to get into the seven pillars and the deeper signal that our body's actually trying to communicate to us when something like this shows up. Um, just a reminder, we use the phrase pregnant women. Um, Every now and then I get somebody that's like, why don't you say pregnant people? Y'all, that's not us. If that matters a lot to you, go somewhere else. Um, that's what we use here. Women get pregnant, women have babies, precision matters. Also, sovereignty first. This is why we have conversations like this. Every woman who receives a preeclamptic diagnosis is a whole person. She is a whole woman, and she deserves, she has the right to informed, unhurried decision-making options. And this lecture is not a fear lecture. I'll share some facts, but it's more of a fluency lecture. Fear contracts our bodies, fluency expands, and we want expansion because that's how we grow. So let's get into it. The global burden of preeclampsia. Right now, it's about 4.43% of all pregnancies globally. And that translates into about 42,000 maternal deaths in the year of 2023. So about 16% of all maternal mortality. That's not a small number. There's about 10 million women affected per year worldwide. And note that in Latin America, preeclampsia is the number one cause of maternal death. So in the United States, what does that look like? Right now, it's about 5 to 8% of all US births are affected by preeclampsia or related hypertensive disorders, and it's continually rising. Like the biggest drivers, hold on, let me take a sip of my tea here. Like it's not slowing down. Obesity, metabolic dysfunction, chronic hypertension, y'all, assisted reproductive fertility contributes to this. Racial disparities have been largely unaddressed, and some will say advanced maternal age. Prevention is underrated and underfunded, and reactive care is overbuilt. Ew. So, what you won't hear also is that preeclampsia does not end at delivery. When a woman is preeclamptic, there is a 4 times increased risk of hypertension within 10 years postpartum. There's a 2 to 4 times increased risk of cardiovascular disease long term. And about 50% of women with a preeclamptic history are hypertensive at 10 years. Let's get here. Let me see if I want to. Okay, let's keep going. So preeclampsia is a spectrum, and the classic triad is hypertension, edema, edema. I say edema because I think of proteinuria, but protein in the urine. Hypertension, edema, and protein in the urine. Those are like the three things. And the current understanding centers on hypertension and then organ dysfunction. So it usually starts out as gestational hypertension and then preeclampsia without kind of severe features. Then you get preeclampsia with severe signs and symptoms. Then it develops into the HELP syndrome and then full-blown eclampsia. Okay, that's the spectrum. So, how is it diagnosed? Usually, there's the blood pressure threshold. It's greater than 140 over 90 on two separate readings that are about 4+ hours apart. And that's after 20 weeks in a previously normal woman. Um, if somebody was preeclamptic in a previous pregnancy, they're probably monitoring this a bit closer. If they were hypertensive before pregnancy, they're monitoring this a lot closer. Um, Also, protein in the urine or thrombocytopenia, that's a decreased platelets, renal insufficiency, impaired liver function, pulmonary edema, or new onset cerebral or visual symptoms. Note that protein in the urine is really no longer required, according to ACOG and some in that camp. They're largely, the current ACOG definitions are largely based on expert consensus and not primary research. Interesting. So there's two different um, onset diagnosis, let's call it that, of um, preeclampsia prior to 34 weeks and then after 34 weeks. After 30 weeks, 34 weeks is late onset preeclampsia, and that's more common. That's about 80% of the cases. And it is oftentimes the origin has to do with maternal metabolic stuff. There's different underlying biology. With this one, there's better short-term outcomes, but this one also still carries a long-term cardiovascular risk. And as coaches or practitioners, if you're listening to this, this will probably be what you see the most or exposed to the most. The early onset prior to 34 weeks is usually a placenta-driven pathology. Um, there's poor trophoblast invasion, and we're going to get into that in just a second. This one has more severe maternal fetal outcomes, obviously. There's higher reoccurrence risk, so in the next pregnancy, greater mitochondrial involvement, and definitely a long-term cardiovascular risk. Before we get into placenta, y'all, we're going to get into later mitochondrial. And I do think the mitochondria, this is affecting the mitochondria on the cellular level. So let's talk about placentation. Y'all, I'm sorry, English was not my first language. It is, but my first language was Texan. So what is placentation? Basically, this is the process of forming and organizing the placenta. This is important. This is kind of nerdy. Just listen for a minute. And this is specifically how the placenta attaches to the uterine wall and establishes the vascular interface between the mother and the fetus. So the core of it is the trophoblast invasion. After implantation, specialized fetal cells called the cytotrophoblast differentiate into invasive cells that burrow into the uterine lining and then into the walls of the maternal spiral arteries. This is important. Their job is to remodel those spiral arteries, transforming them from narrow, high resistance muscular vessels into wider, low resistance conduits that can deliver large volumes of blood to this placental space. So, this is a two simultaneous happening process. Structural, meaning the chronic villi, that tree-like fetal structure, develop and anchor into the uterine wall, forming the physical placenta. And then vascular, where the trophoblasts invade and remodel the spiral arteries so that the maternal bloods, floods the space right at the pressure, at the right pressure and the volume for the baby to extract oxygen and nutrients. Y'all, in a healthy pregnancy, this happens between weeks 8 and 18. So this is why the first trimester is so important. And some people don't even pay attention to the first trimester. Um, by the end of the first trimester, the spiral arteries should be fully remodeled, widened, denervated, and no longer responsive to maternal vasoconstriction. So with preeclampsia, this is the thread that binds. This process is incomplete. The trophoblasts don't invade deeply enough that the spiral arteries stay narrow and reactive, and the placenta is chronically underperfused from early in pregnancy. This is long before symptoms appear, right? Because a lot of the time, symptoms, or especially if you're first pregnancy, you're not going to observe these symptoms till later. This is why the dis-ease starts at implantation, even though the diagnosis doesn't come till later. The clinical picture is the body's downstream response to something that failed to happen months earlier. It's wild, huh? I think this is one of the most important things and why preconception health matters. So, in my opinion, we know that emerging research shows that health of the placenta is largely influenced by paternal DNA. So, yes, maternal and paternal can influence preeclampsia. That's what I see right here. I don't know if you see that. The trophoblast is a fetal tissue, which means it carries paternal DNA. The mother's immune system has to recognize this and tolerate the semi-foreign tissue for placentation to succeed. If it doesn't, like when the maternal immune tolerance is incomplete, trophoblast invasion is impaired, spiral artery remodeling fails, and you get the poorly perfused placenta that drives preeclampsia. So, this is why several well-documented epidemiological patterns make sense once you understand the immunology. First pregnancies carry a higher risk of preeclampsia because the mother has never been immunologically primed to that paternal antigen profile. Her system hasn't learned the tolerance yet. Um, Changing partners. So if you're a woman or you know somebody, you're coaching a woman um, that had an uncomplicated pregnancy prior with a different partner, maybe it's a second marriage or something, I don't know, that's still going to be treated as a first time immunological exposure. Um, the things that help longer sexual cohabitation before conception is protective because there's evidence that prolonged exposure to paternal antigens through seminal plasma primes maternal immune tolerance before pregnancy begins. Donor sperm pregnancies carry elevated preeclamptic risk. Um, let's see what else I got. That's about it I want to share on that. What I want you to like, this is the birth it lens, right? Like the paternal health shapes sperm epigenetics, lifestyle influence on our genes. So the father's metabolic health, oxidative stress load, mitochondrial function, nutritional status all influence epigenetic programming of the sperm. And that programming shapes the trophoblast quality, how invasive, how well organized, how robust the placenta process will be. A father who is metabolically compromised, so let's say chronically sleep deprived or nutrition malnourished, nutrient depleted, is contributing a different epigenetic signal than one who is not. So just make note, preconception care is a two-person job. So what happens in preeclampsia? So there's poor placentation, right? Now there's restricted blood flow. Now the placental distress signals are out. They're inflammatory, anti-angiogenic factors. Um, and now next, there's a systemic response. The kidney, vasculature, and liver, they all try to compensate and they overshoot. So then you start to see things like high blood pressure, protein in the urine, um, organ dysfunction, where I hope you just got like this started this started before conception. Write that down. Oh, so what are some risk factors, right? Like obviously lifestyle. Um, we talked about some non-modifiable risk factors, such as first pregnancy, switching partners, if there's any kind of autoimmune issue, um, family history, multiples, those all might be non-modifiable risk factors. But modifiable risk factors play a big role here. Chronic hypertension, diabetes, insulin resistance, obesity, poor nutrition, sleep disruption, chronic stress, sedentary lifestyle. Y'all, the game could be changed here. All right, so what is standard routine OB care? Usually it's serial blood pressure monitoring. They might look at protein in the urine, depending on the provider now. They might look at some labs like a CBC, CMP. Um, they might look at the request fetal growth scans, biophysical profiles. Um, They might prescribe antihypertensives. They might prescribe low dose aspirin. Um, they might prescribe magnesium sulfate, hospitalization for severe cases, steroid administration if preterm. And then the definitive treatment is delivery. That seems to be the only cure conventional medicine offers. And with that, it's a timing game. They're balancing maternal safety and fetal maturity. And it's usually 37 weeks for non-severe cases and earlier if necessary for severe cases. The midwifery approach is a bit different, but remember they're operating, especially if they're CNMs, CPMs, they're operating within the same diagnostic framework, but the experience of care is often profoundly different. So midwives see their clients, a, the time span they hang out with their clients is a lot longer. They see them more frequent. They usually take on a smaller load of clients, so they're going to look at you as a whole person. And you usually get about 30 minutes to an hour with your midwife each time you see them. So that's usually there's more time and attention, so earlier identification of risk factors through that attentive relationship-based care. Midwives like to go nutritional route first, which is great. So think about protein intake. Are you consuming enough minerals? What, real food? What does that look like? So even, in their first prenatal visit, they're asking about diet and they may start to intervene then. They might throw some supplements around. They might say, hey, have you tried this? Have you tried that? Think about magnesium, calcium, some vitamin D. Um, and then just thinking about the relationship in general between the client and the midwife. In my opinion, that's a little more nervous system friendly than a 15-minute appointment. So anyways, and in my experience, all the midwives that are licensed, when it's necessary, they do refer out. But there is a conventional gap. What conventional care consistently misses? The metabolic substrate that made the soil fertile for preeclampsia. Like I said, this starts long before. Nutritional deficiencies built up over years, not just like pregnancy is the great magnifier. It's going to shine the light on, I would say, things in your closet, baggage, holes, deficiencies, all those things. Sleep, circadian rhythm, nervous system, how those are cultivated, practiced, the quality of those things in your life, those are going to be risk factors if you're not paying attention to them. The postpartum cardiovascular handoff is neglected, and this is real, and I think this needs more attention. And then, obviously, we've talked about preconception as prevention. Absolutely, yes. So I also want to share kind of the traditional birth keepers and a little bit insight there, as they've been managing hypertensive pregnancy for centuries before the word preeclampsia even existed. So with indigenous midwives, they lean on food as medicine, community as medicine, ceremony as regulation. Latin America, they might lean more on herbal tonics, liver and kidney support, some spiritual cleansing. I'm about to sneeze. Um, I- Ayurvedic medicine. Excuse me. They're going to balance the doshas. They're going to use nourishing foods, oil massages, rest protocols, um, traditional TBAs in Africa. They might lean on plant medicine, community holding, ritual boundary setting, and then traditional Chinese medicine practitioners, blood stasis, kidney liver imbalance as a root cause framework. Excuse me. So I want to hit on some plant medicines and nutrient or like herbal nutrients. These are not cures, but they are great long-term support that builds a physiological substrate, and the window matters. I drink these regularly, daily. A lot of these, I will make I call it a sun tea, and it's like a herbal infusion. I make a big mason jar of nettle leaf, dandelion, raspberry leaf, and some other things, but we'll get into those are the three main ones here. And I let it sit for about 12 to 24 hours in the sun. And then in the summer, I drink that, I'll put it in the fridge and I'll drink it cold. In the winter, I'll just drink it at room temperature. But these are very, very um, mineral rich, um, great for hydration. So nettle leaf is really good for building and kidney support. Dandelion is a liver and kidney support. Garlic, that's a vasodilator. So if you're not cooking with garlic, throw it in there. Last night I threw like four things of garlic in our Korean beef lettuce wraps. Red raspberry leaf. This is a uterine tonic and very mineral dense. Uh, Midwives love this one. Hawthorn berry is a cardiovascular tonic, and oat straw is really great for the nervous system. So get those in your life. If you want to think about food as medicine, right? This is what midwives like to do first. Protein, 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 protein. Adequate animal protein supports blood volume expansion and placental development. And this is now validated by modern nutritional research. That's big stuff. Lily Nichols has talked about this, so go check out her blog. Liver support, think beets, dark leafy greens, bitter herbs. The liver regulates the hormonal signals involved in vascular tone. A burdened liver is a preeclamptic risk. Mineral density, think calcium-rich foods, magnesium-rich foods, potassium. That's electrolyte balance directly affecting the vascular tone and kidney function. And then anti-inflammatory fats, omega-3s, pasture-raised meats, olive oil, good stuff. Fish, yes. And then let me see, what did I want to say? I wanted to hit on this. So I get a question a lot about aspirin. I don't lean one way or another strongly yet on this. Um, but the most evidence-based supported pharmacological prevention strategy for high risk women is to take 100 to 150 milligrams of aspirin, low dose aspirin nightly before 16 weeks. This does not say normal women. This says high risk women. And what I've seen is women just taking aspirin just to take aspirin, and that does not sit well with me. Um, So this is a conversation I would have with your midwife or your provider if this is you. If you're a coach or a practitioner and you have a client like this, definitely chat about it. Like this might be the best, least invasive intervention option. Um, and I want you to understand this is in that first trimester. So you gotta know that's where the significant benefits are. After the 16 weeks, that benefit is significantly reduced. So, yeah, just make note of that. And I will say, like, if you're a coach or a practitioner, this whole conversation, right, is really good to know the big picture, know the terrain, understand the evidence tiers, calcium, vitamin D, have strong data. You can go down rabbit holes there. Um, Real food is the strongest. Um, Definitely, this is where labs come in, and having a baseline of labs is really, really profound. Uh, I would say tools to have in your pocket there. And then this is obviously very individualized care, and prior to conception is huge. This is where the seven pillar framework as prevention comes into play. Because preeclampsia is a multi-system failure, right? And it starts prior to conception. So I just want to touch on a few, and then we're gonna wrap it up. But sun, circadian rhythm, is our first pillar, and that's a biological input. Sunlight drives vitamin D synthesis, which is one of the most studied nutrients in preeclamptic prevention. Morning light anchors the master circadian clock in the suprachiasmatic nucleus. Circadian rhythm disruption has been linked to pregnancy complications, including preeclampsia. So, outdoor pregnancy, like getting outdoors, is not just a luxury. I think it's a biological requirement. And I would pass that information on. I want to hit on sleep, right? Because sleep is super important. Sleep deprivation drives cortisol, drives inflammation, and drives insulin resistance. All three are direct preeclamptic risk factors. And then the last one I want to hit on right now is fitness, because we've already talked about nutrition, and that's a pillar of ours. But fitness, movement is vascular medicine. Regular moderate exercise improves endothelial function. It reduces insulin resistance, which is a major preeclamptic risk amplifier. It supports healthy blood volume expansion, and then it reduces stress hormones and allostatic load. Inside of the BirthFit community, we get into all the pillars, but we're wrapping it up here. I'm keeping it efficient. So, as I said before, I think preeclampsia is a mitochondrial story, and this is emerging science. And remember, science is constantly evolving, it's never settled. But mitochondrial dysfunction at the core, right? Because if there's synctio, well, I'm not even going to try to say this word. If there's a dysfunction, an impairment in the development of the placenta, that's right, that's where the issue starts. And those have showed altered mitochondrial structure and function. So think oxidative stress and cell damage. Electron transport chain activity. Complex 4, which is where cytochrome C oxidase activity, that is significantly reduced in preeclamptic placentas. So think less overall energy. Um, Mitochondria are light responsive. This is where I want to tie this in. And disrupted light environments, artificial blue light at, at night, indoor lifestyles, those are going to be big stressors on the mitochondria. So the placenta has its own clock genes. And when that master circadian clock is disrupted, the placenta clock may fall out of sync. Right? Our master clock is in the SCN, the suprachiasmatic nucleus, and it's synced up daily by our light input. So that's why daily, immediate sunlight in your eyeballs, daylight in your eyeballs, close to sunrise, is so important. When light inputs are chaotic, they're not uh, routine, ritual, the master clock becomes unreliable. They don't know when to digest food. They don't know when to release eggs and do, they don't know when to do things. The placenta clock, like that is going to be influenced by the genes it receives. And that's going to influence the trophoblast invasion timing. So it's very interesting. Shift work. Think of if dad's doing shift work, that's a big deal. Think if both mom and dad stay up late at night watching TV, that's artificial blue light. Eating patterns, y'all. If you're eating your biggest meal at night, that's throwing off your circadian rhythm. Anyways, so lifestyle matters. And then what I want to wrap with is, you know, every issue with signs or symptoms is our body trying to communicate something. So, in this sense, what is the language that preeclampsia is saying? What is our body, the woman's body, trying to say with this? Um, her body's trying to force resources through a bottleneck. That's the blood pressure rising thing. What else in this woman's life has nowhere to go? Now we're getting deeper. Um, the placenta doing more than it was designed to do alone. What is doing the equivalent in the woman's life? Preeclampsia frequently appears in women who are overextended, undernourished, undersupported, and operating from an empty cup, a chronic threat rather than safety. Um, in Chinese medicine, hypertension maps to liver qi stagnation and kidney deficiency, excess pressure with nowhere to go, depleted root. The treatment principle is not suppression, but circulation and restoration. Indigenous framework, high blood pressure in pregnancy has been linked to carrying too much emotionally, energetically, relationally. The intervention is not pharmacological alone, it's communal, it's ceremonial. And then through a somatic lens, the body holds what the nervous system cannot process. Chronic threat response equals sustained vascular constriction. Safety is not a feeling, it's a physiological state with measurable cardiovascular effects. So just something to think about. I appreciate the deeper lens, and I really think that's why individual risk, individual, like taking the individual and looking at them as a whole is so important. Um, you know, the biggest thing here is you can't just put a pill on it and mask it. You can't just deliver because you're not fixing the root issue. Um, if you deliver early when that baby's not ready, then that's going to have downstream effects, negative effects. So I hope this conversation, this thought process discussion helped you out a little bit. Let me know what you thought. Be sure to leave us a review. If you liked it, go to YouTube, leave us a review. Go to iTunes, go to Spotify. I would greatly appreciate it. And that's it, y'all. Thanks so much.